Okay, it's a pleasure to introduce Dr. Bexar. He is a geriatrician and he's an associate professor in the Division of Community Geriatrics and Family Medicine. He was director of the AIDS unit at Cristo Santa Rosa, and now he is very active developing a hip fracture project for Cristo Santa Rosa and the university. Dr. Sa has he was trained at the Cleveland Clinic and he completed his fellowship at Duke University. He serves on the editorial board of Cleveland Clinic, Journal of Medicine, and also he's on the planning committee for the Geriatrics conference. And today he will tell us about managing hip fractures in the elderly.
Thank you. Thank you, Dr. Musi. It's certainly my pleasure to be speaking with you today about a topic that I've certainly given a fair amount of thought about, and that's hip fractures. We'll be reviewing current diagnosis and management for this condition. So among today's objectives, we'll be reviewing the epidemiology of hip fractures, as well as discussing current diagnosis and treatment options for hip fractures. Finally, we will discuss ways that we can possibly improve outcomes for patients who have sustained hip fractures. So I'd like to sort of begin by talking about this gentleman. His name is Walter Bruni. He was actually the oldest American male documented or verified. This sort of following his health is sort of, I think, informative. He really didn't have any health problems until the age of 64. He was diagnosed with colon cancer, but that was treated and he did well, and really had no other major health issues until the age of 108 when he sustained a hip fracture. Okay, and then over the next few years he started having more problems with mobility, eventually started using a cane, then a walker, then a motorized scooter, although he maintained his faculties throughout his life. In 2011, he contracted pneumonia and passed away at the age of 114. So I mentioned this story as a way of illustrating that for many patients, especially many men, especially if they get over the age of 100, actually hip fractures are quite likely going to be part of their health history. So in terms of the scope of the problem, hip fractures are, although less than 20% of all osteoporotic fractures, we know that the incidence of hip fractures increases with age. Women, especially over the age of 50, have a 15% lifetime risk for developing hip fracture. Unfortunately, there's been no significant decline in mortality since the 1980s. And in fact, mortality has actually been gradually increasing in men. So in the first year after hip fracture, the mortality rate averages about 20%. And certainly we know that most patients who have had a hip fracture have decreased functional status afterwards. They never go back to their previous level of function. Okay. Although, as I said, hip fractures are less than 20% of all osteoporotic fractures, they cause the majority of fracture-related health care expenditures and mortality in both men and women over the age of 50. The vast majority of hip fractures come to medical attention and require hospitalization. In fact, hip fracture is the second leading cause of hospitalization in elderly patients. Hip fracture risk varies significantly between countries. It's interesting to note that the difference in incidence between countries is actually greater than the gender differences within a country. And we know from a study done by John Canis and colleagues that high-risk countries are found in Northern, Central, and Eastern Europe, as well as the Middle East, and then also, for some reason, Argentina and Taiwan. It's been postulated that lifestyle or socioeconomic status may be a major contributing factor to this observation. So this is a figure that shows both age and gender-specific incidence of osteoporotic fractures, specifically at the vertebrae, hip, and distal forearm, or in other words, the wrist. Okay. And as you can see, vertebral fractures, and for that matter, most of the major osteoporotic fractures are more common in women compared to men. This is particularly striking for wrist fractures. It's interesting to note, though, for hip fractures, as you look at the 85-plus age group, men actually surpass women, okay, in terms of incidence. Again, I think that's something that's not well appreciated. In terms of worldwide incidence of osteoporotic fractures, we see that, as of 1990, the number of fractures in Europe and North America were pretty close, similar, although Asia had the most osteoporotic fractures. However, that trend is going to be accentuated even more by the year 2050, where Asia will, at that time, have more osteoporotic fractures than North America, South America, and Europe combined. So this is a major health concern as it relates to Asia in particular, especially the developing economies of China and India. So this could have important economic repercussions. In terms of the incidence of women, we know that this occurs twice as often in women compared to men. The mortality from hip fractures, however, is lower in women compared to men. Within the United States, in terms of ethnic groups, we know that...
I'm sorry.
Sure.
So after age 70, hip fractures are more common in men?
Well, as you can see from this diagram, really the incidence increases dramatically in the 80s for men.
Oh,
so that after age 85, they actually are more common in men than in women.
Okay.
Yeah, 85 is sort of cut. So going back to looking at U.S. epidemiology, we know that Caucasians are the highest risk ethnic group, whereas African Americans are the lowest risk. Okay, and Asian Americans and Hispanics are somewhere in between, although closer in risk to the African American group. And this more or less illustrates that. Okay, so the lowest risk female group are African Americans. The lowest risk male group is actually Asians, and the highest risk group in both men and women are Caucasians. Interestingly, if you look at the hip fracture rates in the United States, again, this is looking at 2001 data. If you see right here, Texas. Texas is, well, actually the South in general is sort of a hotbed for hip fractures, and in particular Texas, especially around the Panhandle and East Texas, for reasons that I don't think any of us really know why, but it's particularly relevant to us practicing medicine here in the Lone Star State. So in terms of, there was a study that was published about 15 years ago looking at prevalence of osteoporosis and hip fractures in persons age 65 and older in the United States. And it's interesting to note that the self-reported percentage of patients who thought they had osteoporosis is greatly underestimated in both men and women, but gets actually worse as people get older. We also note that the percentage of hip fractures, steadily increases as people get older, which is not surprising, but certainly females outpace males in terms of numbers, especially in the 85 and older group. Okay, this is a figure that shows mean bone mineral density at the femoral neck, which is the most common site for hip fractures in men and women. And part of the reason why we are, see lower rates of hip fractures in African Americans, for example, is that they achieve a higher peak bone density, especially in their 20s and 30s compared to the other ethnic groups. And so they have they're able to lose more without having negative consequences, if you will. And sort of with this radiograph, I segue into a discussion of the diagnosis of hip fractures. This is courtesy of one of my former mentors, Dr. Ken Lyles at Duke. And I sort of like using this slide because it illustrates a little known sign called the Throckmorton sign. Do people happen to know what that is? Okay, so this is sometimes known as the John Thomas sign, but in male patients, the penis almost always points to the side where the hip fracture is. Part of the reason is that when people have a hip fracture, especially the femoral neck, oftentimes the leg is externally rotated. Okay. Hip fracture risk factors, I think, is important to review in terms of making the diagnosis for a hip fracture. And certainly the main one is osteopenia and osteoporosis. But certainly we know that advanced age, female gender, certain chronic medical conditions like hyperthyroidism, certain medications like steroids, nutritional deficiencies, especially calcium and vitamin D, as well as a sedentary lifestyle and the use of tobacco and alcohol all put people at increased risk for having hip fractures. Now, hip fractures are certainly noted to be associated with a number of complications, as many of these occur during the course of hospitalization, but these can include blood clots, pressure ulcers, various infections, especially of the urinary tract, pneumonia. Decreased functional status is really what contributes to increased morbidity that we see with hip fractures. And certainly, if you had one hip fracture, that does put you at increased risk of getting another hip fracture. In terms of symptoms of hip fractures, the most common ones are the inability to move or bear weight immediately after a fall. Okay? And certainly this is a major reason or major cause for why older adults present in the emergency department. Severe hip or groin pain, stiffness, bruising, and or swelling in and around the hip joint. Also shorter leg on the injured side, as well as outward turning of the leg on the injured side. And these are all findings with hip fractures. In terms of the diagnosis of hip fractures, most can be detected using just plain X-ray films. Okay. However, occasionally hip fractures can be occult, and this raises the question of CT versus MRI. Okay. But we know from at least a couple different studies that MRI scans are more accurate than CAT scans in diagnosing occult hip fractures. And as a consequence, you can start effective treatment sooner, have shorter hospitalizations, and overall decreased medical costs. So if you're suspecting an occult hip fracture, think about getting an MRI scan. Unless, of course, there are contraindications for an MRI scan, such as having a pacemaker. Now, in terms of the assessment of hip fracture risk, there is something called the FRAX, the Fracture Risk Assessment Tool, which was developed by the World Health Organization. And this was developed to evaluate fracture risk in patients. It combines clinical risk factors as well as bone mineral density readings at the femoral neck to determine fracture risk. And this scale was developed from population-based cohorts from Europe, North America, Asia, as well as Australia. And basically it reports two different 10-year probabilities, that for a hip fracture as well as that for any major osteoporotic fracture, which includes vertebral, wrist, shoulder, and hip. In terms of the treatment of hip fractures, certainly the initial treatment is getting patients to surgery. And certainly one can either repair the hip joint with hardware using screws or rods. Sometimes these are also referred to in the literature as nails or pins. You can replace part of the femur, and this is sometimes referred to as a partial hip replacement. Or you can replace the entire hip joint, and this is a total hip replacement. And we'll talk a little bit later about the reasons why one might select one versus the other. After surgery, rehabilitation, physical rehabilitation is next, and certainly physical therapy and occupational therapy are the mainstays for physical rehab. And then finally, it's important to think about medications, and specifically bisphosphonates, and we'll talk more about these in a little later. And then there are a couple other newer agents, denosumab, also known as Prolia, and teriparatide, also known as Forteo. These latter two agents may be particularly helpful in patients with severe osteoporosis, that is, T-scores of minus 3 or less, or greater, or I should say less. In terms of conservative management, in some instances, patients and families may choose not to undergo surgery. And certainly, there may be cases where this is reasonable, especially when a patient has advanced dementia, is non-ambulatory at baseline, or has a critical and or terminal illness. Okay? However, for the majority of patients, the consequences of no surgery are significant pain, development of leg length discrepancies, one leg being shorter than the other, as well as immobility and eventual contractures. So the goals of surgery are primarily pain control, ambulation, and lessening of complications. So this figure shows the different types of hip fractures. And the top row shows the most common types of hip fractures, intertrochanteric, which is on the right here. And then we have transcervical, so the femoral neck fracture, as well as subcapital. Okay. All right. Less commonly, you may see subtrochanteric, which is a fracture of the greater trochanter, and then the fracture of the lesser trochanter. Now, in terms of types of devices that can be used to fix the hip joint, we have, as I mentioned, the rods or pins or nails. Okay, these can be used, for example, in femoral neck fractures. If you have a little more extensive fracture, as shown here, a compression screw may be helpful, and this also then attaches to the shaft of the femur. Hemiarthroplasty refers to a partial hip replacement, and then this is a total hip replacement. Oftentimes, if a patient has also hip osteoarthritis, the preferred hardware is the total hip. Okay. The thinking being that eventually they need replacement as the osteoarthritis gets worse. So, might as well just go to that. All right, in terms of acute complications, we know that most patients do not have medical complications after hip fracture repair. However, we know there are some postoperative medical complications which can occur, most common being cardiac or by pulmonary, GI bleeding, often due to blood thinners that patients are placed on to prevent venous thromboembolism. Patients can also develop TIA or stroke or have a combined cardiopulmonary complications. I think it's important to note that renal failure and septic shock are actually rare complications after hip fracture. In terms of long-term complications, we know that sometimes, despite our best efforts, chronic pain can result. And one common example of this would be when the prosthesis loosens, since it's set in osteoporotic bone, okay? Which I think makes sense intuitively. Cognitive impairment also can occur, especially after prolonged anesthesia. GI bleeding from the DVT prophylaxis, as mentioned before. And then finally, you can get leg length discrepancies as well post-surgery. Then this can secondarily lead to falls, additional fractures, worsening osteoarthritis due to uneven wear of joints, and chronic leg and or lower back pain. However, there is a fairly easy solution. You can get orthotics or shoe inserts, and oftentimes, but this will take care of that particular problem. So regarding physical therapy, as you recall, that's the second part of treatment for hip fractures. I started thinking about, some of the more common questions that might occur as to the timing, like when would be the most appropriate time. And really, we know that immediately after hip fracture repair, physical therapy can be started, and that's actually preferred. So the location or the venue in which physical therapy should occur, we know that inpatient rehab facilities, or IRFs, often provide superior 12-week functional outcomes compared to those who are treated in skilled nursing facilities. Okay, so inpatient rehab is something that is very important.
Quick question.
Yes.
Excuse me. Is it common to get 12 weeks of inpatient rehab? I'm a family doctor, and
Sure.
it sure seems like I'm thinking 6 weeks or something is fairly common. And then a while back, a few years ago, I read that some extended PT, like over a period of like 6 months, not all inpatient, has been really great, getting these folks back up and preventing further morbidity.
Right. I think, despite this being in the literature, the majority of patients who get physical therapy after hip fracture, they get that in a skilled nursing facility. Okay. I think part of it is availability. There aren't nearly as many inpatient rehab facilities in most places, most cities. So I think that's part of the reason why we see that pattern, despite what we know from the literature. In terms of intensity of exercise, we know that high intensity exercise performed in the home is feasible in patients after hip fracture repair. Okay? So home care certainly can play an important role in improving outcomes. Okay? And we know that patients who get home physical therapy in addition to, let's say, physical therapy in a skilled nursing facility often do better. Okay. So that's something to think about. After patients have had their standard rehab, if they are still are having problems with their mobility, home physical therapy should be considered. Does dementia preclude participation in a rehab program? Generally no, although certainly with advanced dementia, that would can be an issue. But then again, one might opt for conservative management in that situation, especially if someone is already have immobility or are not able to follow instructions required for physical therapy. Certainly we know that going back to home physical therapy, that improved ambulation at 1 year is better with the addition of home physical therapy. I'm going to talk a little bit about bisphosphonates in terms of medical treatment for hip fractures. There are 4 main medications in this drug class that are being used today. These include alendronate, brand name Fosamax, which is given orally once a week. Risedronate, also known as Actonel, which is given monthly by mouth. Vandronate, or Vaniva, is can actually be administered two different ways, either orally once a month or subcutaneously on a quarterly basis. And then finally there's zoledronic acid, or Reclast, which is once a year IV injection, or infusion I should say. Currently, based on Cochrane reviews of the literature, we know that both alendronate and risedronate are indicated for secondary prevention of osteoporotic fractures in postmenopausal women. Etidronate, which is an older drug, is only indicated for secondary prevention of vertebral fractures in postmenopausal women. And currently, Cochrane reviews are being done of both abandronate and zoledronic acid. So hopefully within the next few years we'll have an answer, but I suspect that they will be helpful for osteoporotic fractures, especially the zoledronic acid. In terms of possible side effects, complications, and interactions, certainly we know that esophageal reflux, esophagitis, gastritis, these are things that are mentioned on by the manufacturers of these drugs. Osteonecrosis of the jaw, certainly feared complications, especially of dentists and orthodontists, especially after a dental procedure. Oftentimes they recommend stopping bisphosphonate at least a month prior to a planned dental procedure. Atypical femoral fractures involving the shaft of the femur are something that was described by Dennis Black and his colleagues in the New England Journal in 2010. And in terms of major drug classes, I wanted to note that proton pump inhibitors can actually reduce the anti-fracture efficacy of bisphosphonate, since PPIs are quite commonly used in the general population. So this brings us to ways that we can improve outcomes for hip fracture patients. And I'm reminded of the saying by Aristotle that the sum is greater than the sum of its parts. And maybe you'll get to see that in a moment. In terms of hip fracture repair, there's the question of the first 24 hours. Is that essential? Certainly we know that generally this is preferable, and for a host of reasons, which include reducing the rate of complications, basically, such as non-union, avascular necrosis of the femoral head, urinary tract infections, pneumonia, decubitus ulcers, blood clots, functional decline, as well as death. However, the main reason to delay surgery may be to optimize the patient's medical conditions. For example, their cardiopulmonary status, since we know that among complications, cardiac and pulmonary complications are the most common. The question about preoperative stress testing versus empiric use of a beta blocker. We know that stress testing can sometimes lead to a lengthy delay in hip fracture repair, and based on the Goldman criteria, hip fracture repair is considered an intermediate risk surgery or procedure. Hence, empiric beta blocker therapy can be started and does significantly reduce perioperative cardiac complications without unnecessary testing and minimizing complications related to delay of surgery. In terms of patients with COPD, we know that the increased use of regional anesthesia and urgent scheduling of hip fracture surgeries may improve outcomes for these patients. On the other hand, if they are smoking, or if general anesthesia is used, or if there are delays in surgery, these are actually modifiable risk factors that lead to worse outcomes. Diagnosis and treatment of osteoporosis can be improved in COPD patients to reduce the incidence of hip fractures. All right. Gerontologic advanced practice nurses have been shown in the post-acute care setting to improve patient functioning in instrumental activities of daily living, or IADLs, up to a year after hip fracture. However, no differences in health, depression, or living situation were noted with the advanced practice nurse treatment group. Also, we note that multidisciplinary rehab improves hip fracture outcomes based on a systematic review of randomized controlled trials. A 16% reduction in the pooled outcome, which included death or nursing home placement, was achieved with multidisciplinary rehab. Routine provision of organized or coordinated care does seem to benefit hip fracture patients, at the same as it has been shown to benefit stroke patients. So in some ways this is not surprising based on what we've observed in other cohorts, other patient populations. I wanted to also go over some practical tips for patients after hip surgery. Okay. Certainly we know that sometimes the best solutions are the simplest ones. Okay. And some of this I thought, could be very helpful for primary care providers in regards to counseling their patients after they've had, hip fracture repair or just in general hip replacement. Certainly, try not to cross your legs. That's a fairly simple recommendation. Crossing the legs can lead to dislocation of the prosthesis. Sitting in deep chairs or can also lead to the same problem long after one has had the surgery. Oftentimes it's helpful to keep the hips higher than the knees, okay, when sitting. So this can be achieved using cushions as shown in this picture. In general, want to keep your feet aligned, okay, don't turn your toes inward, okay. Another hip precaution, don't bend your affected hip more than a 90-degree angle, okay. So no deep knee bends. Also, when lying on your back, do not roll or turn your affected leg toward the other leg or turn your toes inward. Okay. And then finally, when lying on your side, you can use pillows, okay, to keep the alignment of the legs, but do not cross your legs, especially if the top leg is the one that has the prosthesis. Certainly we know there are certain situations that are particularly challenging when it comes to hip fracture management. Vertical hip fractures, where, again, you involve the trochanter as well as the femoral neck. This can be associated with increased risk for hip fracture repair failure because of the large surface area involved. Pathologic hip fractures with signs of metastatic disease. In terms of reconstruction, the focus is on providing early function, okay, and then probably also pain control. Concurrent hip and pelvic fractures, certainly intractable pain can make it difficult for patients to undergo physical therapy, especially when they have pelvic fractures as well. And then the rare situation where you might have a bilateral hip fracture. Again, do you repair both at the same time, and then how do you rehab such patients if you do? And then finally, repeat or redo hip fracture repair. And again, the question the orthopedic surgeons are going to ask, is there any good bone left where they can fixate the prosthesis? Okay, especially since, again, these patients typically have osteoporosis. So some areas for future research. We know that the relationship between patient variables such as demographic factors and comorbidities, type of fractures, whether it be intratrochanteric, subtrochanteric, or subcapital, and post-treatment outcomes, pain, mobility, and mortality. still don't really know exact relationships between these different variables. Also, looking specifically at the type of fracture and post-treatment outcomes, or implant variables such as the position, material, method of placement, or implant design itself, what effect this has on post-treatment outcomes. And then finally, the type of intervention, whether it's internal fixation versus arthroplasty, and what effects the choice of surgery has on post-treatment outcomes. So these are all areas that are ripe for research and study. I've included some online resources which you can give to your patients with hip fractures. Both the MayoClinic.com and ClevelandClinic.org websites have some excellent materials. There's also some additional materials listed here, as well as this. This is actually a UK website. So again, there's quite a bit of material online for patients to read if they have questions. And these are some examples of different types of textbooks on hip fractures and hip fracture repair, especially in the elderly. So again, they're certainly resources for clinicians and healthcare providers to refer to as well. And with that, I'll entertain any questions if you have.
I want to know what your recommendations are in terms of concurrent calcium and vitamin D supplementation with those various bisphosphonates and other medications. And the second question is ever estrogen indicated?
So in regards to the question of calcium and vitamin D, certainly for years we have recommended concurrent calcium and vitamin D supplementation when patients are on bisphosphonate therapy, typically twice a day divided dosing. There's some question, although, in patients who have cardiovascular disease, whether we should be giving as much calcium. It might be raising their calcium scores, from a cardiovascular standpoint. So, I think current thinking might be maybe once a day dosing for those, patients with risk for cardiovascular disease. Okay, but I think, again, we're not entirely sure.
I'll put them out in the sun for a few minutes.
Yeah. Put them out in the sun. I think it's important to also review sources of vitamin D in the diet. Most people are not aware that if you skip breakfast, it's very hard to get enough vitamin D in your diet. A lot of the breakfast foods are the ones that have vitamin D, like your milk, your eggs, cheese, yogurt. As well as cereal and some types of orange juice.
Ted, and what is currently the standard of care in terms of what type of hip replacement should be done surgically?
Again, it depends on the type of fracture. Okay, and to some extent, how severe their osteoporosis is. A more extensive prosthesis, like a total hip replacement, requires more good bone to anchor into. Okay, so part of it also is dictated by not only the site and the type of fracture, but the surrounding bone as well.
Those commercials about hip replacement failures, are those just is that a true concern, or these are just lawyers trying to make some money?
Well, I think there are certainly there are some questions as to the which materials may be better in terms of, especially when it comes to the ball and socket joint. Some of the prosthesis, the ball is actually ceramic. Others are metal. Okay, so the ceramic prosthesis seem to be doing better in long-term studies.
Okay.
So, although historically we started out using metal, we're going more to ceramics. Yes.
It seems that for osteoporotic related fractures, bisphosphonates, so I think for years been the first line. You mentioned the two other new classes, Prolia
Yes.
and Forteo has been around a little longer. It may create maybe increase of bone density, greater amount, shorter amount of time. What's your thoughts on, you know, I mean, maybe skipping bisphosphonates if a patient wants to, or you would like to see them to do what we want to do, which is to prevent a second fracture.
Right. I think it's important that, once someone has had a hip fracture, we know by definition, clinically, they have osteoporosis. However, there is a benefit in knowing just how severe their osteoporosis is. So getting a bone density scan or DEXA scan, I think is often helpful in terms of selecting what type of medical therapy may be most appropriate. For example, if someone has a T-score of -3 or less, you may want to not go to one of the oral bisphosphonates, but go directly to IV reclast or even Prolia. Or there's a recent paper that came out in the last couple months suggesting that combination therapies also seem to be superior to monotherapy, especially, for example, denosumab combined with teriparatide, or reclast combined with teriparatide. So combination therapy is going to be something that we'll see more of, especially those patients that have real severe osteoporosis. And I've seen T-scores as low as -6. Yeah, so I mean, those patients need, maximal medical therapy.
I think there is a discussion, how long you're supposed to treat the patient with bisphosphonates. They say over several years, after several years, probably additional beneficial. Even have a side effect such as osteoporosis of the jaw.
Yeah.
What is your thoughts on that?
Certainly a lot of people are concerned about osteonecrosis of the jaw, but it is a fairly rare complication. It's certainly gotten a lot of publicity, and certainly dentists in particular, I think, are quite aware of that, and perhaps they're also fanning some of the concern about that. But, in terms of, other types of complications, certainly by far, esophagitis, gastritis are much, much more common side effects. Osteonecrosis of the jaw is probably even less common than atypical femur fractures.
So do you suggest patient on the drugs for a few years, then take it off, not forever, or?
Right. So in terms of, there has been some evolution in thinking in regards to the use of bisphosphonates. 10 years ago, we basically put everyone on bisphosphonate. They stayed on it indefinitely. Okay. But more recent studies in the last, I would say 5 years, have suggested that, if a patient's bone density, repeat bone density, has actually increased, then you might think about stopping the bisphosphonate. Okay. On the other hand, if it has continued to decrease despite bisphosphonate therapy, you might consider, accelerating, going from an oral bisphosphonate to maybe either IV reclast or Forteo in particular. And then perhaps denosumab may also be part of that equation as well. And I guess the gray area is, in regards to patients whose bone density hasn't significantly changed despite being on a bisphosphonate. I think a lot of people are probably still keeping them on a bisphosphonate, in that situation.
Thank you.
But again, we don't have good data to say what would be the most appropriate.
Thanks.
Thank you.
Any questions? Thanks so much.
All right, thanks, Ted.
Very well. Appreciate it.
Very
You're welcome.
Yeah, fine.
When she hurts me, it's 'cause we're in love. When she hurts me, it's 'cause we're in love. Bruises like a kiss, her lips are like